Good afternoon, everyone. My name is Susan Spencer, and I will be moderating this session, Staying on Your Feet is Sweet, an evidence-based practice initiative. A few reminders before we begin. Out of respect to our presenter, please be sure to silence all phones and electronic devices while we are in session. You can access session and speaker details, including the slide deck handouts, in the AMSN mobile app. To claim the contact hours, you must attend the session in full, and after the session concludes, you can complete the session evaluation in the mobile app for this session. If you have questions about the mobile app, please visit the information desk located at the registration concourse level. Next, please allow me to introduce our session's presenter. Kristen Mackwell has been a registered nurse for over 20 years with varied experience in both acute and outpatient settings. She holds a Doctor of Nursing Practice degree from Grand Canyon University. Kristen received her Master's of Science in Nursing from Walden University and her Bachelor of Science from Cedar Crest College. She is currently enrolled in a PhD program in nursing at Walden University. Kristen works as a clinical nurse specialist with a focus in research and innovation, and is the NICHE coordinator for Hackettstown and Newton Medical Center. She serves on the CMSRN recertification committee and took over as chair in 2024. Kristen professionally is involved in her local AMSN chapter as president, and additionally, Kristen routinely speaks at the state and national level. Please welcome Kristen.
Can we give her a hand for that great introduction? So she did say that, I have over 20 years of experience. Please understand I started nursing when I was 5. And I apologize if you've been in my other sessions and may have heard some of my other jokes. All right. So I have no conflicts to disclose. I am from New Jersey. Is anybody familiar with New Jersey? If I cuss, I'm really sorry. Please feel free to call me out on it. I also am a geriatric millennial. So that means I'm not always up on my terms. And one of the things that I can tell you is I gave a presentation regarding nursing and social media recently. And there was a bunch of newly licensed nurses. Who knows where Florence grabbed her nurses from for the Crimean War? What profession did she take them from? Who knows? I think I heard it. Somebody say it louder. Yes, the streets. So I called them hookers. Apparently, the PC term right now is sex workers. So if I do, unfortunately, use a term that is not PC, please feel free to correct me. We can all learn from each other, okay? So I work for Atlantic Health System. It is a mid-size integrated healthcare system located in New Jersey. Most people know our flagship hospital, which is Morristown Medical Center. Has anybody ever heard of Morristown? Yeah. I don't work at that big fancy hospital though. I work up in the rural hospital, which is, one of them is under 100 beds and the other one is under 150 beds. So 2 pretty small rural areas. Now, when you think about New Jersey, what do you guys think about? What comes to your mind? The shore. What else? You don't have to pump your own gas. That is correct. Dunkin' Donuts. No, maybe down south. I don't know. I'm up north. But you think of the shore, maybe you think of like Jersey City, Bayonne, Hoboken, like those city type areas. Yeah, no, where I live, it takes 45 minutes to get to the closest mall. and you are more likely to see a farm than you are another car on the way to work. So just to kind of give you perspective. So there's a lot of social determinants of health that happen within our centers because there's no public transportation. If you don't have a car, you don't have a working car, things get a little challenging. So we have a bunch of designations. One of the things that I do is our Nurses Improving Care for Health System Elders Coordinator, or NICH, which is focused on making sure that our geriatric population is getting the best evidence-based care. We are a NICH exemplar site. We are also age-friendly, committed to care excellence. We have the highest designation for that as well. Most of the population we serve are 65 years and older, so it's really important that we know how to take care of that population. When you think about that population, who here has hearing difficulties? And not selective? Who here has issues maybe with neuropathy? How easy is it to pick things up? How about sight? If you guys have like an extra pair of glasses at home, put some Vaseline on it. That's how a lot of our older adults are seeing. Yeah. Now I want you to think about that. Then they come in the hospital. Do they know where anything is in the room? And what else do we do to them? We hook them up to an IV pole, right? Everybody's got an IV and IV fluids. And then what else do? We need strict I&O, so what do we pop in? A Foley. Or we give them what? The PureWick, which then makes them trip and fall as they're trying to get out of bed. So we really have to look at our geriatric population. Hackettstown is where this project did occur. Like I said, we're licensed for 111 beds. Our inpatient census is usually around 70, so small, and that's split up between ICU, cardiac tele, and med-surg. We do serve 10 different communities, and we have around 3,800 admissions a year. This is our institution's professional practice model. Whenever I present, I always like to talk about a professional practice model. Does everybody know their professional practice model from their organizations? I see some head shaking, yes. It's really important you know the structure for your professional practice model. So for our hospital, I know everything has to go through shared governance. Who here has to go through shared governance and you feel like it's 5 months later when something's finally approved, right? And then our nursing theorist is Emma Jean King. She's not one of the more popular ones. Is anyone else familiar with her? Her theory really speaks to our nurses because it's all about getting to know the person that you're working with and then setting attainable goals. Let's say you have a patient who hasn't been walking a whole lot. What are the recommendations for exercise? 30 minutes, like 3 to 5 times a week. But if you have a patient who hasn't been that mobile and you try and set that goal, what is that patient gonna do?
I'll do it.
This chick's bananas and she's chunky herself. Let's go see her walk that much, right? So we have to set attainable goals. How about twice during the shift, we walk at least 200 feet? So that's why we really like Emma Jean King. Within the petals of the flowers are really all of the things that our nurses try and embody. And this definitely went to quality, teamwork, research, education, and then advocating for our patients. And if you didn't know, New Jersey is the garden state, so that's kind of why we have the flower there. So what is a fall? Is everybody familiar with this definition? This is the CMS guideline definition of a fall. How do we kind of sneak around this? Have you guys ever walked someone to the bathroom and they're going down? you're like, oh, friends, I am not doing that paperwork. There is no way. So you go, okay, Mrs. Smith, we're going to go down to the floor. Because if you have contracted with your patient that you have a plan to descend to the floor, guess what it no longer counts as? A fall. How many people do you guys think fall every year in hospitals? Too much? Absolutely. Almost 1 million, you're right. There's almost 1 million falls in hospitals every year. Now, those are the reported falls. What about those shady falls where I'm like, okay, Mrs. Smith, we're going to the floor? I want you to think about those. So our fall rates are really not necessarily accurate because it's dependent on people being transparent when they report and having transparent practices. At our hospital, unless there is a plan in place before Mrs. Smith starts falling, guess what we have to do? Call it a fall. Now, if somebody does fall, what are some of the potential injuries? Breaking a hip, hematomas, they'll wind up needing surgery, skin tears. What if they hit their heads? So there's a lot of negative things that can happen. Now, if your patient falls in the hospital, how likely are they to go back to the level of care that they were before they fell?
That's likely.
They are 75% less likely to be able to go back to the same level of care.
Wow.
So when they fall and they have those injuries, because we're talking about injuries we can see, right? Or that we can visualize on an X-ray. Can you really tell if somebody's pulled a muscle? And if they've pulled a muscle, are they going to be mobile? Are they going to walk? They're going to stay in bed, right? Now, what happens if our patients stay in bed? Who knows how much one day in bed adds on to somebody's recovery? It's actually 7 days. So if I stay in a bed for 24 hours and don't move, that adds 7 days onto my recovery. So I want you to think about, do you guys have those doctors who make everybody bed rest when they come in the hospital? And how easy is it to keep reminding their attending to change that order? Easy or not so easy? Not so easy. Now I want you to think about falls. Is it one singular thing that actually causes a fall? No. It's like a comedy of errors, right? And is each patient the same or are they different? They're different, 100%. The fall might be because of medical equipment. Maybe their knee just goes out because they have arthritis or they were supposed to get a knee replacement and they haven't gotten there yet. I want you to think about that older population. How well do they take care of themselves? When they were younger, what was the medical model? It was all reactive, right? And now what are we doing? Everything's very proactive. How do we get you to be the right weight, get your blood sugars in line, get your blood pressure okay, keep your cholesterol down? So we're taking a population who's not super healthy, and now they're sick and in the hospital. They also don't know the environment. And I don't know about you guys, but on night shift, what do all the night shift team do? They turn off the lights, which is important to promote sleep. But what does that do to the patient who's in a new environment and already has trouble seeing? So there's lots of things that we may not think about as we care for this population. So there's intrinsic, extrinsic, and environmental factors. Some of the intrinsic things, do you guys remember back to intrinsic? A lot of times people are very anxious in the hospital. If you think something bad is going to happen, what happens? Something bad happens 100%. So if I'm worried and anxious that I'm going to fall, I'm more likely to fall. Now, how many of your patients are anxious in the hospital that we're not going to get them to the bathroom? Then we have to look at extrinsic factors. How's their mobility? How's their gait? And then environmental, I think we've really touched on already. So we need to look at our situation. We assess all of our patients, right? And we trust that fall risk assessment score, right? But guess what? What does the evidence show about those fall risk assessments? They're only accurate in about 75% of patients. So that means a quarter of your patients that are falls or fall risks, you may be missing. It also means people who don't need to be on fall precautions, what are we doing? We're putting them on fall precautions. And then what does that do to them? Are they super excited about their stay? I've had a couple who figured out how to turn off their bed alarms on their own. Like if you're that flexible and you didn't get hurt, I think you're probably okay, right? Do you guys have that too? Okay. The other thing that we don't necessarily think about with our falls is people who don't speak English. So how many of your patients is English not their primary language? That is not captured within any of our fall assessments, but that makes them much more likely to fall. All right, so when we look at our patients from a background perspective, what do we want to know about them? History of falls. If they've fallen in the last 6 months, what are we doing? Fall care plan, yellow socks or non-skid socks. We're putting their bed alarm on. We're doing everything, right? We're going to throw the kitchen sink at them. How many of you guys have fallen in the last 6 months? Now, if we think about that, if somebody now tried to put a fall alarm on me, what am I going to do? You're right, I'm going to turn that alarm off. I'm going to watch them. If it's not a bed I know, wait for my opportunity. So we start to really look at that. The other thing too is if somebody falls while they're in the hospital, we know it's going to add to their length of stay, right? And it's also going to increase the cost of their hospitalization because what do? We now x-ray everything and send them for a CT of their head, right? To make sure nothing bad has happened. So it drives up healthcare costs. When we start to look at fall practices across systems, everybody seems to have universal fall precautions, right? So you guys yell out, what are some of the things you do for like universal? Wristband, chair alarm, bed alarm, socks, blanket. Oh, you guys put a yellow blanket on the bed? We do too. Stay with the patient while they're toileting. Put them near the nurse's station. Declutter the rooms. We might give them one of those roller belts, which doesn't count as a restraint if they can verbalize how to take it off. How well do those lap belts really work though? So the Posey alarming belt is more helpful. All right. We all have standardized assessments. So lots of people use the Johns Hopkins, some people use the Morse. What are some of the other ones you guys use? Or did I hit them all? The Schmidt. Some people use the Tug.
There's one that we have built in Epic that we're not, I'm a part of the school committee and we don't even know what it means. Yeah, it means it's documentation. Yeah.
So predictive models are really driving healthcare now. How many of you guys have a deterioration index, whether it's the Muse or the Epic DI or the Rothman index? But all of those predictive models are dependent on what? Documentation. Friends, when do nurses usually document? At the end of the shift. How helpful is that for you guys at the beginning of your shift? Right? Especially if it's a new admission. So they have a lot of value, but we have to make sure we're doing, that real-time charting. However, when you have 6 patients and you have 6 different families and maybe 3 different doctors, how easy is it to document in real time? And can you say, hold please, I really need to get these notes in. The other thing we look at is individualized care planning. I don't know about your electronic health record, but to really do an individualized care plan in mine is not so super easy. So we wind up using like that comment box a lot. The other thing that we have found that has been really helpful is in the Age Friendly initiative, we started asking all of our patients what matters. When you start to ask questions about like what matters to you, you find out sometimes that this person really loves Labradors. And if they're confused, we'll try and find a book that has pictures of labs in them so that they have it at their bedside. So we have that extra time to get in the room if they're trying to get out of bed. If the patient can't answer that, who can you ask? The family, right? How often do we truly pull the family into care? Or how often are you guys using the family as a sitter because you don't really have a sitter and you need the aide on the floor, but you're never going to tell anyone because you know your hospital will have a heart attack, right? And then the next thing are your post-fall procedures. Does anybody do a swarm report or like you do that post-fall huddle? How effective are they? So those have opportunities to be streamlined. So some of the things that I think we need to really look at is what was happening, how many patients did the nurse have, how many patients did the aide have, and when was the last time that patient was actually checked. So look at your post-fall procedures and how many questions is that debrief? And then say, is this really realistic to do? Or am I just filling out another paper for quality? Everything that we do should have meaning. It shouldn't just be some other task that you're doing because someone said you should. So when you think back to evidence-based practice, just because we've always done something that way doesn't mean we should continue to do it that way. All right. Some of the things I do want everybody to think about as they think about their falls are there trends? Are all your patients falling on Saturday night between the hours of 9 and midnight? What's going on Saturday nights? Is that your night where you're a little bit lighter staffed? Is that a heavy admission and discharge time? What might be contributing to that? Because if you can see a trend, then what can I do? I can say to leadership, hey, Is it possible that we can up staff during this time because this is when we're all having our falls? An extra pair of hands may be helpful. The other thing to do is look at your skill mix. How many people go onto their floors and you realize that you are a dinosaur? And that some of the nurses don't even know what you're talking about because they've never heard or seen it. Unfortunately, we don't know what we don't know, right? So really start to look at skill mix and make sure that you have at least a seasoned nurse who can help those newly licensed nurses. And if you can't staff that way, who can be their immediate resource if they need something? You know, love the nursing supervisor, but when she's covering or he's covering the house, how much time can they dedicate to my one med surg unit to make sure that they have what they need? Or they may get there after a fall has already happened and the nurses didn't really know to escalate that. Next, we want to look at our demographics. How old is our patient population on our floor right now? Who just had surgery or a procedure? So for the 24 hours after someone's had a procedure or surgery, they had sedation, right? Do we necessarily redo a fall score when they come back from that procedure? I'm pretty sure all of our policies say we're supposed to, but do we actually do it? Not usually. You're just like, they're breathing? Great. Are they in pain? I hope not. I'm a very realistic creature. The other thing that you want to look at is just where your patients are on the unit. Now, if you have a unit that's predominantly 65 years and older, how do you triage who goes near the nurse's station? And is that a conversation that you guys are having every shift at your huddle? Do you guys do huddles at the beginning of every shift? And in that huddle, do you guys call out who's a high fall risk? You do? That's awesome. Next is medication review. So outside sedation, how many of your patients are getting Ativan, Xanax? Maybe they're getting a sleeping pill. And who gives melatonin on their floor? What time do you guys give your melatonin? 9 p.m. Do you know when the melatonin actually starts working? It starts working between midnight and 1 a.m. Now then what happens at 4 a.m. or 5 a.m.? The lab comes to draw their blood and they're all kinds of confused. So look at the timing of your medication. So like, if you are gonna give your patient melatonin, if they're gonna go to bed at 10 o'clock, really they need it at 7 o'clock. You really need to give melatonin about 3 hours beforehand. The other thing is if you give Lasix twice a day, what time are you giving it at? Who here is still doing 9 a.m. and 9 p.m. for Lasix twice a day? Yeah? All right, so look at that. Maybe we really need to change that to like 8 and 4, and then that way they're not going to the bathroom all night. So 8 and 4 is really a good time to give Lasix because then they should be able to sleep soundly throughout the night. And then the last thing you really want to know are your policies. When was the last time you guys cracked open your fall policy and looked at it? Every 3 years, most policies are updated. There may be things in the policy that you're not aware of. All right, so when we really look at literature, mobilization programs are important. Does anybody have a mobility aid on their floor? So this is one of the things that we were able to get based on the literature. We were able to get that mobility aid. Mobility aids not only help reduce falls, but they also help reduce length of stay because our patients are moving. Remember, an object in motion stays in motion. If I keep you in the bed, what's going to happen? I'm going to add on to your recovery time. Next are those language barriers. Really have to be on top of those non-English speaking patients. Now, do you guys use like Seracom, or do you use like the iPad, or do you have in-house translators? iPad? Do you guys leave the iPads in the rooms? No. Or do you guys leave them in the room? You guys do? So like mixed in here. But if my patient doesn't speak English and I take that iPad out of the room, how are they communicating with anyone? But how long does that take then for somebody to answer it? Then you have to get the iPad, call up the person to translate. It takes a lot of time, and that time may lead to a fall because that patient may get frustrated, right? And then the final piece is team engagement. When we look at our teams, are you guys teams that like pizza? Or are you more the team that wants like an ice cream party? Or are you the team that just wants like a gift card to the cafeteria? So how do we get everybody involved and all on board and engaged and invested in making sure our patients don't fall? So we had some ideas. Obviously, looking at the literature, it's not one thing that's going to help decrease your fall rates. You have to do a mix of things, and the most important thing is to individualize it to your patient. So there were a couple things that we did. The first thing was, when you guys, your patients are lying in bed, where do we put the stop, call, don't fall sign? We took ours, because they used to be on the end of the bed, on that nice little whiteboard, you know, the one that we try and remember to update, and if we don't, we really hope leadership doesn't do rounding. That one. We took that and we put it on our ceilings. And we put it in English as well as Spanish, because those are the two primary languages for our area. Who still does hourly rounding? Do you know what the literature actually says? It's not about doing the hourly rounding, it's about doing purposeful rounding. So some patients, you might only have to round on them every 3 or 4 hours. Other patients may require you to round on them every hour. But again, it's about individualizing that care plan to the patient, so we're doing what's best and what's right for that patient. And let's face it, how many people are actually doing hourly rounding on their patients? So we did a PDSA, Plan, Act, Do Study, or Plan, Do, Study, Act, sorry, I did that in reverse. How familiar are you guys with this model? Pretty familiar? So basically in that planning stage, everybody comes together, they identify the problem. Now, as you're identifying a problem, it's important you have everybody at the table. Most of the time, from a leadership perspective, what do leaders think the problem is? Is the staff actually doing what they're supposed to be doing, right? Or is that why our fall rate is up? People aren't actually doing their hourly rounding or purposeful rounding. From a staff perspective, resources. I'm only one human. I can only be in so many places at once, right? But if everybody can come together and can really look at the falls that have happened and identify some commonality, that's what you really need to do, because then you can create an intervention that should be sustainable and everybody has given their input. If everybody gives their input, then what does everybody have? Ownership for the process working, right? It's very different when you're included in the process versus somebody coming and saying, okay, X, Y, or Z happened. This is what we're all going to do now. When somebody says that, what do you guys all think in your heads? What office has that person been hiding in? Do they even know what happens on the floor anymore? So then you're going to educate everybody about what the change is, right? And then you're going to do the change. And then what's our goal? And when you start to look at goals, I very much encourage people to say, we're going to decrease falls by 1, 3, or 5% in the first 3 months. Is it likely that you can probably decrease it by one of those metrics? Hopefully. And then when you guys have that win that you actually have decreased it by at least 5%, what does that give your whole team?
Confidence.
Motivation, right? What we're doing is working. So set realistic goals and then see where it takes you. So team engagement is really important. How many of you guys, when you walk into work, feel like you're all zen? No? I have one. If I had a prize, you would get it, my friend. As we walk into work, everyone should be calm. Can you change what assignment you're getting? If you get there early enough, maybe, and no one has seen the report sheet, yes, that is true. But when we work with a team and you trust everybody that you work with on that team, what happens? It's a good day. It's a good day. Some of my favorite shifts that I've worked, we were short as anything. But because of the people that I worked with and how well our team worked together and engaged, they were the best shifts and we got out on time. So what strategies are you guys using to foster team engagement? So I can tell you that we have different boxes in our break room that have fidget toys, they have coloring books, they have essential oils. We have this crazy little Buddha that you plug in and you follow his light pattern with your breathing and it's nice and chill. We also asked our teams, what would you like? What would be meaningful for you? Do you want a pizza party? Do you want ice cream? Like what actually would make you excited to buy into this project? Do you want to know what our team said? They wanted candy and mocktails. They didn't really want mocktails, but that's the best we could do. So as we set these goals of decreasing fall rates, we celebrated them. We had this huge, crazy candy bar. And then what happened the next cycle when we looked at our fall rates? It fell even further. So finding out what it was that was meaningful for the team was really, really important. So how do you get your team to engage? How do you grab them? And then how do you keep them engaged? And no matter what you do, who's going to be in that room? I don't know what they're thinking. This isn't going to work either. Do you guys know those people? So then how do you neutralize that person? How do you think you neutralize that negative Nancy? Sorry if anyone's name is Nancy. You're going to take Nancy. You're going to say, Nancy, you are the most experienced person on our unit. We value you so much. Isn't this wonderful? We think you should help us lead this. And then what is Nancy going to do? She's either going to close her mouth, and she's definitely not going to say anything negative, or she's going to be really excited that you are respecting her expertise and her longevity on the unit. So it's all about how do you grab different people and how do you get them engaged? And let me tell you, we have some, what's the word I'm looking for? Some very seasoned nurses on one of our med-surg nurses. In fact, one of them was like, I could be your mother. Like, that's makes me feel really young, thank you, right? So these are some of the things that we did to modify our practices to try and help reduce those fall rates. So in the evening and night shift nursing administrators workflow, they now go to every unit and say, who's your high-risk fall patient? And then guess what they do? They actually go in the rooms, they make sure whatever we said is supposed to be in the room is in the room. I feel like there's gremlins in hospitals. Have you guys ever worked a shift, you put everything in, and then it's change of shift, and they're like, oh, none of that stuff was in there. And you're like, friend, it was in there. So we have the evening and night shift nursing administrators double checking and having our backs to make sure that the supplies to keep the patient safe are in there. The other thing we started to do was coaching to reassess fall risks. Now, with our fall risk score, if they haven't gotten an opioid or a sleeping pill yet, guess what happens? They may not be a fall risk. But now I give you that Dilaudid for your severe pain, and now what are you? You're a fall risk now, friend. So we started noticing those trends in our newly licensed nurses because that wasn't the thing on their head. It was, I gave them pain medicine so they weren't in pain, but didn't think about those downstream effects. And that comes with experience, unfortunately. How many times have you guys had an unfortunate patient incident and that will never happen again because you learn from that incident? Next, I told you guys we're a rural community hospital. Sometimes resources are limited. But what do patients typically have a lot of? Family. So how can we use the family to try and help us keep this patient safe? You allow them to stay. So if they wanted to, we asked them to set up shifts because we didn't want one person staying for 24 hours. We asked them to set up shifts. You can stay, I would love the help if you want to stay with your family member. Understand though that we don't want you to get tired yourself and get sick. So as long as you have a plan within your family of who's coming in and out, totally fine with it. Now, most of the time when you say you're going to involve a family that way, what does everybody else say? No, then I have to answer questions all night, right? Would you rather be running in that person's room all night as they're trying to hop out of the bed? And then lastly was the mobility assistant, and our mobility assistant was super helpful. So they get everybody who's allowed to get out of bed for breakfast, and then they will get them back in bed if they can't tolerate staying up. They'll try and get them back out for lunch, and then they try and get everybody back out for dinner. In the meantime, they're also walking patients who can walk. So something that we are going to be adding that we've wanted to add are pictures around the unit so that it kind of motivates the person who's walking, like, oh, I really want to get to see the next picture. And potentially for our younger patients, adding QR codes with like fun facts or something like that to encourage them to keep walking. The other thing that we really did was diversional activities.
Delete things
Do you
inside of
guys
an app
have
that
functional
launches.
task cards
Get it.
on your
That's
units?
not how this works.
So when you're dealing with patients who are 65 years and older, I don't know about your population, but a lot of our population does have dementia, whether it's Alzheimer's or Lewy body, whichever, but we do have a large amount of patients that have dementia. So we have a card on our unit. On that cart are baby dolls. There's also something called a busy blanket, and that's really cool. We let the patients keep them, and you can put pictures of their family in the one pocket. There's a zipper, there's buttons, and when you put it on their lap, they start playing with it. And I love when we can put pictures of their family or their pet in there, because then that gives like that opportunity to connect with them on that more personal level. How can I learn more about them? When you know more about your patients, guess what happens? Everybody cares just a little bit more, right? Think about that patient that you thought was the biggest pain in the rump, and then you found out about something amazing that they did when they were younger. And then you started to connect with that person about that. It changes how you care for them, doesn't it? Also on our functional task cart, there's coloring. We also have lacing because a lot of people in that age range used to sew. So it will keep them busy. And then the other thing that we put on there were Legos, because people who built cars or worked on machinery, if you gave them the Legos to like construct and deconstruct things, it would keep them busy as well. We also tried to keep everybody awake during the day. Who here works night shift? What are the worst words you can hear from your day shift nurse? They were fantastic. They slept all day. And then what do you think on night shift? Oh, friend, you better be staying with me tonight, right? So keeping them awake. We also started using, have you seen the hatch lights that they oftentimes use for younger kids? It's like a little light, it changes colors, it's very calming and ambient. We have a couple of those that we started using with patients too, because if you turn them on, they start seeing the lights change, and then they become very focused on the light versus whatever they were doing. Another strategy that we took with diversional activities, has anyone ever seen the animatronic dogs and cats that Joy for All makes? I know that there's other companies that do make them. Joy for All actually gave us a discount on the pets, so we were able to purchase a large amount of them. So the cats purr, their heads move, they look really real. They'll meow. If your patient is annoyed by noises though, there is a mute button on it. So you can mute the cat, but it will still move and respond when it's touched. The same thing with the dog. I can tell you in real life, I'm a dog person, but with robotic pets, totally a cat chick. And I can tell you that they are so realistic. One of my coworkers came in to use the cat to calm herself down after a crazy shift, and she forgot to turn it off. So when I got in the next morning, security's like, Kristen, we think there's a cat in your office. Like, that's because there is, friends. And the batteries were dead, so I guess it stopped meowing around 5 a.m. So I'm really sorry for the patients that were outside that room. The other thing we did were proactive medication reviews. So if you were 65 years or older, guess what I did? I called my friend in pharmacy. Poor Kunal was ready to kill me. He's like, no, I don't have time today. I'm like, oh, but we have to. And we would go over all the medicines together. And if there was anything like on the beers list or anything we thought may cause a fall and wasn't really beneficial to the patient, we reached out to the provider to get it discontinued. The other thing we did was a strict no pass zone. Have you ever been walking past a patient room and you hear them go, help, hey, hey, and you have those people who are like, and they keep walking? We really changed the culture so that when you heard that, even if you knew Betty didn't need anything, you at least stopped. And then we really looked at our patients who were in withdrawal. The other population that we found was falling a lot were patients that were withdrawing from ETOH. So we looked at our dosing for our CWAP protocol, and we slightly adjusted it. Because what the literature really shows is that if somebody is drinking, are they honest with how much they're drinking? So depending on what article you look at, you can take whatever they're telling you and multiply it by anywhere between 3 and 7 times, and that's what they're actually taking at home. Next was accountability. So we really empowered the whole team. This is all in, friends. We are working together as a team to decrease falls because it's important for our patients. So if you see someone walk past a room that has a call light on or a patient calling, what am I empowering you to do? Stop that person and say, excuse me, this is the culture on our unit. Now let me tell you, when they did that to our CMO, what happened? One of our nursing assistants, who's like super excited to be a nursing assistant, she's in nursing school, the CMO walked right past a light that was going off, and she's like, excuse me, miss, because our CMO is a woman, and Dr. Xavier turns around and she's like, can I help you? She's like, we have a culture on our unit. The light's on, you have to go in the room. So Dr. Xavier actually went in the room, she helped the patient, and after, when the nursing assistant found out who she had just said that to, and I mean, she did it in a really professional manner, she wasn't like out of line or anything, you would have thought she was gonna have a heart attack. I think she hid in the break room for about 45 minutes having a panic attack. We had to talk her off the ledge. We're like, it's okay. We all have to keep each other accountable.
I'm not quite.
If we're not holding each other accountable, what are we doing? Now, is it easy to say to one of your peers, like, hey, I haven't seen you get up and round on your patients in a while?
Within teams, so I don't.
How easy is that?
Hopefully it's doing it this time.
It might be easier to take the strategy of, hey, I have to round on my patients. Why don't we round on mine and then we'll round on yours? Because what is that nurse going to remember? Oh, that crazy chick, Kristen, she's watching us. I better make sure I get off my rump and round on the patients, right? So keeping everybody accountable.
I wish it was a lot shorter.
So this is actually a picture of what that looks like. Just pretend you're laying down. But this is what our fall sign now looks like above the beds.
We could get it to where we could email it out, and if they wanted.
And like I said, they really were all about candy and everything else. So we have our candy bar here. We had a hot cocoa bar. There's ice cream. The mocktails are in the bottom right corner. And then they wanted to have some kind of game. So we got an Elf on the Shelf.
That would just keep it.
And we started hiding the Elf on the Shelf all over the unit. And one of our,
I was just
the
thinking,
A&M from our PCU actually dressed up as Santa Claus. And everybody wanted a blanket for Christmas. So we had gotten blankets for everyone, and then he went around and handed them out.
Yeah, well, that's what I was going.
So this was a quantitative quasi-experimental EBP initiative. We looked at our baseline fall rates, which were from January 1st, 2022 to December 21st, 2022. And then we looked at our post-implementation data, which was from January 1st to December 31st. We went from 37 falls down to 24. So not as low as we would like to have gone, but that's still a pretty significant drop when you think about it.
Yeah.
So we got to watch that.
Oh, no doubt.
Falls with injury went down to 0.
I want to just listen to it again myself.
So when you look at it, we were able to reduce our falls by 35% over a year.
As few people as possible.
Now, if everybody did that, what would your units look like?
I know for sure I want to send it to Mary Huff. She's the new secure now.
How many people have a unit goal of decreasing your falls?
Even if it's her and I for now.
I don't think I've ever worked anywhere where that wasn't one of our top things, right?
Pull the information and then make it yours.
So
that out.
Yeah.
When we really look at this,
on this,
it was really about getting the team engaged
and
finding strategies that worked for our patient populations. So when was the last time you guys did a lit search about your patient populations?
I did that. In the
Do you
couple
guys
years
have,
later.
do you have special programs in place like
I went into
niche
teams that
or
were
age
around,
friendly?
and I
So
started
that you are
sharing
making
while I
sure
was,
that you're giving that
15,
evidence-based care to
with
that
them.
geriatric population?
But it didn't seem to work. So this time when I was in teams, it allowed me
Everything that we
to
did was
see
fiscally responsible.
this
We got
screen
money
directly.
from a grant from our
So,
hospital foundation,
and then share.
which helped pay
So
for
big work this time.
some of the baby dolls and busy blankets and the diversional activities,
Only broke you down.
and also helped
Oh,
offset the
gee.
cost of the stickers that we put up on the ceilings. This could easily be replicated.
You did it.
The biggest thing that I want to say for this really was team, and then also the engagement strategies. There are limitations to this. It was one unit at one hospital,
We both can look
and it's a
up.
community hospital, so our population may not be comparable to yours.
I was trying to find
All right, what questions do you guys have for me?
a picture that's on my wall, but it doesn't, it's not inspiring. And then I.
Come on up. I think the microphone is there.
So then I-
Take your time. We have time.
So I brought my.
Yeah, I don't want to do fall paperwork at the AMSN convention. Just throwing it out there.
Okay, I don't want to be termed a negative Nancy, but I do want to know, is there a correlation between safe staffing numbers and patient fall rates?
So it's like a floating
And
shelves.
it's a limitation for your study. Was the admission rate the same
Yes.
the first time you looked at it,
So,
is
and
the-
as soon as all that comes in.
when you looked at it the second time?
Yeah, so the admission rates were the same number of patient days.
Mhm.
And in New Jersey, there is no limit to how many
Oh,
patients one nurse can have. So the nurses in the first cohort had anywhere between 6 and 7 patients, and in the post-implementation, they had 6 to 7 patients.
It's more of the
He's his
CNAs
partner.
that I'm
And I tell
curious
you
about. How many
When I
CNAs?
was watching
Because,
them.
again,
It was a solid 10
I
minutes.
work at John Muir Hospital
Maybe
in
we'll come back
California.
here. And I'll walk over there.
Our sister hospital is unionized, we're not.
Center.
And they have the motto, safe staffing saves lives. And so we've noticed, at least, this is not a study that was done, but usually when you have safe staffing numbers, your falls go down. Have you found any evidence to that?
Straight there.
Honestly, we've seen the opposite. It's like the more bodies there are, the less our team is really up. And I don't know, I know you're looking at me like that, but I can tell you that for a fact. The more staff they have on the unit, the more falls, the
But
more
it's
pressure
different
injuries
the
we've
type of
seen.
staff. It's not just a matter of more staff,
Well,
it's.
one of them
the
is gonna
type of-
go
The type of
this
staff.
way, and then the
We
other
make
two
sure
are
everything is
that
pretty
way.
mixed and there's at least
Just to
one
find
seasoned
out.
nurse on every shift.
Definitely. We don't have to put
And that unit holds up to 32 patients.
Yeah.
The aides usually have 8 to 10 patients
Up here.
apiece.
Yeah, two
Okay.
of them.
And then
One
to follow
upside,
up, how many falls
looking
are,
at time.
do you know, reported when the
That's what I
patient
did my
needs to go to the
thesis.
restroom? Because I would assume that
But this
most
is cool.
falls
Yeah.
occur
Oh,
for
I
patients
want
having
something
to
that's
go
a
to
little
the
different, but
restroom,
I-
regardless of, you know, whether they're taking medications that increase
It
their
does make
risk.
me feel
But
good.
I would say that's a higher number, which would, again, point to
Find
the
exactly
fact
what I
that
needed
you need to have the proper
until I
CNAs
thought about,
listed
well,
on,
I should
or
take my degree
staffed
into
on the
my
floor too.
office.
So interestingly, on this med surg unit,
Yeah.
mostly what we found it was that it was medication related, which is why we so heavily focused on the meds. But our sister med surg
I took a
unit
picture.
at like our other hospital, they found most of their falls were secondary to toileting. And so they did institute like a Q2-hour toileting program, and
I
they
know,
have the
my
same
friends
staffing
are-
numbers that we
I'm-
do.
I'm a
Thank you.
You're welcome.
Well, hopefully next week, I might just go ahead and put a facilities. pick
I
it
just have a
in.
quick question about the mobility
Yeah.
aid. Is
Mhm.
who
Then I
is
might
in that
take
role? Is that a tech? Is it a CNA? Is it a volunteer? Is it a student?
To where everything is.
So a lot of times it's a PTA, like a
what I
physical
did.
therapy
I
assistant,
hadn't seen
will
these
take
two,
that
or
role.
these three.
They're very versed with moving patients, getting them up, getting them walking, and they feel comfortable walking patients that maybe an aide wouldn't. That is something that I can tell you we've seen.
I don't know. I don't
You're
sit on that side of the room.
Thank you.
Yes, it does.
Yeah.
It is a little.
Oh, get your level up.
The orange side needs to go up a little bit.
They get the level.
So the question is the mobility aid shared across units. Yes, we do share our mobility aid with the med-surg unit on the other side. So, and that unit is 21 beds.
Yeah, tip the orange
So
up
is
just a
it
little bit.
one mobility aid like per shift? Or how is that structured?
So really the mobility aid is only there during day shift. They don't have that resource on night shift.
There.
I had two things. One
Stuff
is
like that bothers
we
me.
had our maintenance
I
painters
appreciate
paint
your assistance.
call don't fall
Yes, yes, yes.
to decrease the cost. So we didn't have stickers and stuff like that. So, and then
Yeah.
it's bright yellow on all of our.
That's a
adult
good
floors.
idea, though.
So
I
if
like that.
anybody's looking for, don't have the money for stickers and stuff like that, it's just, they painted the ceiling tile. The second thing is at the beginning, you said something about if you have a contract with the patient,
Yeah, right,
about
we do.
lowering them down to the floor.
That's it.
Because we've seen an increase
Trying to get out
in,
next to it, right?
in that we're getting them up and they're having syncopal
But
episodes
that
due
doesn't
to,
make you start getting
various
things
reasons.
Yes.
together.
Yeah.
But we count them as
Finishing this
false.
up?
So is that like a CMS or
So
in your
according
state?
to CMS, if you
Okay.
contract with the person, like if you start going down, I'm going to lower you to the ground. Technically, it doesn't count.
Okay, thanks.
It's all like however your quality team wants to word it.
Okay, thank you.
Well, maybe we got it wrong policy.
All right, and if you guys want to get in contact with me, feel free, okay? Thank you so much for coming.
Well, we looked that up though.
But who heard it from CMS, right?
I don't know.
This thing was fighting that thing vehemently.
Well, no, we looked at the policy, remember, or the,
But I thought the policy said if you lower them to the ground, that's all.
it is.
That you break the plan.
Yeah, we looked up what the CMS standard was. And that's what it was.
If you lower them to the ground,
Mhm. If it's a, how do they put it, unintentional
they said,
descent or
it's
body movement or something.
breaking the plane. But what she just said is not a plan. I don't know what she getting her.
Where's she from though? What state?
I don't, Jersey, I don't know. I gotta look again. I thought she said it. I thought she said it.
Because that could be a difference too.
I guess. Well, I thought CMS was more, what's that, isn't that, I'm a lot better.
I think we still fall under their guidelines, so.
Yeah, we all do. Just check.
I want to see if I got it.
You better.
Fair.
I need to check and see if my son got one. All right. So I think I'm gonna